Hello, everyone. Happy Wednesday. And I am super excited and grateful for this opportunity to have someone so special joining us today. Ericka, how are you doing?
I'm great. Thank you for having me, Maritza. This is very exciting.
I know this is long overdue. I have been following you and we became friends, and I'm going to share with our audience
Yeah.
how we met and all the things. I have some people joining us. Please let us know in the comments where you're watching from. If the audio is working fine, if you're able to see us and hear us okay, give us a thumbs up and let us know in the comments as you join us. So, thank you again so much for having us. This is one of those conversations that I have been so desperate to have, and I cannot thank you enough for taking the time off your busy schedule to allow me to ask you questions and help our audience and dental offices across the country really dive deep into. Dr. Ling, how are you? Thank you for joining us. Sound is okay. Everything is good. So we have some doctors joining us. He's an old
Awesome.
client of mine. So thank you for being here. You are going to really love this
Okay.
conversation because Ericka is someone that I personally know and admire, and she's a good friend of mine. But I just want to help put everyone the context of who she is and why it is so important for you to tune in, watch till the end, and stick around. Okay, so Ericka, besides being a friend and a mentor to me, is a dental billing coach who helps dentists across the country build, grow, and scale their billing departments. Number one, to increase collections and ultimately unlock hidden profits in their practices. Okay. She draws from 28 years of
I
work
started when I was 5.
experience. Say that again.
I said I started when I was 5.
I mean, it's just amazing, right? So 28 years of work experience, hundreds of continuing education courses, dental coaching from the industry's top mentors, right? And she has helped over 30,000 dental practices with their dental billing guidance, okay? And her love and passion for today's evolving dental economy, right? So, one of the things that she believes is, and I share this with her, and this is why I'm so excited about this conversation, is that the dental billing landscape is changing so rapidly. And to remain relevant, right, in today's economy and billing market, you need to both be tech savvy and you need to stay on top of the coding updates, which are changed yearly, if not, all the time.
Mhm.
And so that's to paint the picture, right? um Last week I had a like I hosted on my own the whole topic about PPO networking and allowing yourself to have better reimbursement through strategic contracting. And today she's almost kind of like that reinforcement to what we need to do in this economic landscape, right? So to before I dive in and I start asking you the questions and I let you make your own introduction, um, and tell us a little bit about you besides the dental billing, expert. Here are some things that are really interesting that I want to make sure that I bring out there, right? Ericka is the host of the Dental Billing Podcast, which I encourage everyone listening to make sure that you add it to your list of podcasts that you listen to. I listen to it myself. She is also the founder of the Billing Appreciation Day, and she now has this front office Lab A Dental Front Desk certificate program for your billing, department admins in within your practices, right? And has recently released her first published book. So everyone, give her a thumbs up and help me support
Super
my
excited. Yeah.
friend. Called the Dental Billing Guide. So now this is available on Amazon. So I encourage everyone watching and listening to follow Ericka, to pay attention, because I have worked in the dental industry. She started at 6. I started we've been there. And so I have a lot of admiration for her work, and she's someone that
Likewise.
I definitely take my hat off
Likewise.
every time I have a conversation with you. So thank you so much again for having us. Before I ask you the questions, tell our audience who you are and what is Ericka like regularly when you're not looking.
Well, thank you so much, Maritza, for having me. And what am I like outside of coding and billing? I'm an outdoor runner. Love out. That's where I get all the ideas out of my head. But other than that, you can find me just totally geeking out on anything coding and billing. Most of the time, it's what I love doing. And I don't know. That's kind of a sad answer, right? Because it just says I don't do anything but run and then study coding and billing. But it is really what I love doing. I don't have small children at home, so it's just me and my toy poodle. So if I'm not taking care of them, I'm running around doing errands. It's just I don't have a very exciting life outside of work.
Yes, your life is very exciting. I admire you so much, and you've done so many things. You've founded so many things. So congratulations on all of that, all of your success. So I have come up with 5 questions to ask you to pick your brain.
Mhm.
And now, for those of you watching who can benefit from these 5 questions, right? I have dentists who have been who are established practice owners who are either struggling with their PPO reimbursement, but also they have a billing department that is not optimized. So we have the issue of the poor reimbursement with dental insurance companies. And then we also have all of these changes that are happening and the lack of understanding, awareness, and training from the coding and the billing side of the operations in a dental practice that these two, it's kind of like the perfect storm for you to have a struggling practice rather than a thriving practice. And so again, last week I spoke about how to optimize your insurance reimbursement. I have other videos out there that you can watch about that particular side of things. And so today I came up with 5 questions. And if you have time, every time Ericka and I get on a conversation, it's almost like the world stops and we are like,
we totally geek out about it. Yeah.
so I came up with 5 questions. If you guys have your own questions, you can post them on the chat.
Please.
And she is here to help answer our questions. So this is your opportunity to get these questions asked. So let's dive in right in, right? Let's tell me, what are some of the most common challenges you see dental offices struggling with when it comes to billing?
So so many offices don't pay attention to how billing is just a piece of the entire dental revenue cycle. And I think that we think of billing as something that is compartmentalized as an individual, right? So when we talk about, or when I ask a dentist, how is your billing department, in your opinion, on a scale of 1 to 10, how would you say your billing department is performing? I usually hear something along the lines of, well, my biller, so it's compartmentalized or it's referred to as a biller's performance. And when we're speaking about the most common challenges that a dental practice faces with regards to the entire revenue cycle, I would say number 1, it starts with your breakdown of benefits. Your breakdown of benefits, not receiving proper insurance verification when we're verifying insurance. I can give you an example of that because I'm also an active biller. I do billing every single day for multiple offices. And the challenges that I face as a biller start at the beginning of the revenue cycle, such as verifying that a patient is eligible, however, not verifying Say, for example, a Prophy. I just had a patient yesterday. I was checking, I was verifying what the patient's copayment would be for tomorrow. And the patient is scheduled 6 days shy of when they would technically be eligible for the Prophy. So we're going to get a denial. If that patient actually makes it into the office, we're going to receive a denial because nobody paid attention to frequency and history. They just stopped at eligibility. So we have to think through frequency, eligibility. That's the front end of the revenue cycle, but it does affect the performance of the overall billing cycle, right? So that's the number one thing that I see, is that on the front end of the revenue cycle, we're not paying attention to the details that matter. And what I see is that a dental practice is losing money. And by money, I mean, this is money that doesn't even make it to your annual profit and loss statement. This is financial silent leaking. It's not even, you're just not collecting it, and it is collectible based on the things that you're doing every single day. So I would say, honestly, Maritza, that's the number one way that offices are just bleeding financially, and it's unnecessary. Outside of that, it's just entering the information into the practice management software. But if you really want me to get granular, I can. Not positioning your fees correctly. Part of the analysis that we do, and this is why Maritza and I work so well together, is I look at write-off percentages for my clients. I don't do anything about it. I bring it to your attention, to the doctor's attention, but billing is my thing. That's my jam. Coding, billing, getting the claims paid the first time, training individuals to do that. That's my jam. But to take a look at the whole package, to take a look at the overall billing department, I do also understand, since I get paid based on collections, I want to make sure that your fees are properly positioned for your zip code. And when I take a look at that across the board, I find that offices are also bleeding financially because they're in the 30th percentile for their zip code, or they're in the 40th. And you and I both know, Maritza, the percentile spectrum doesn't even begin until the 40th. And sometimes you find offices that are in the 15th percentile. That just means that
it's real.
The fees are so low, and we're talking about going out of network with really low fees. And, there's just so much that affects the revenue cycle that we have to pay attention to. So we can talk about positioning your fees. We can talk about, a weak or a strong breakdown of benefits. And then also utilizing your practice management software. This all affects how you're getting paid.
So the most common challenge, just to circle back, and I think you said something so important, which is one of the biggest challenges is in the revenue cycle. It starts with the verification, and there's a threefold to this. We have positioning of the fees, we have the software, and then we have the verification process, which is the very first. And you said something, paying attention to the details. That's so crucial and so important. And that was awesome.
Add one thing right there on the breakdown. If there's one question that we need to start asking on our breakdown of benefits, and this is just a bit of information, that unsolicited advice, right? So one of the things that we need to start asking, because the billing landscape is changing from direct contracts to the umbrellas and leased networks and all of that, we need to start asking on the breakdown which fee schedule will be used to calculate the benefits for this plan. I find a lot of times, and this applies to out-of-network offices as well, I don't think a lot of offices understand that. So just in general, across the board, in or out of network, we need to ask, as we are obtaining the patient's benefit information, and this is not available on a fax back, but we do need to know this, which fee schedule will be used to calculate the benefits for this patient's plan. Which fee schedule is going to be used for this patient? we can ask the operator or the representative something as simple as that, because how many times, Maritza, do you see, we're calling Guardian, but they're going to use, let's just say, Aetna's fee schedule, right? And we miscalculate treatment, and thereby we bleed financially. So just a little extra piece of advice.
That back to that networking, PPO positioning of the fees topic that I discussed last week, and I have other videos on that. But to your point, I had a dentist reach out to me recently about a change of strategy, and although I support and when it makes sense for a dental practice to make that change, there is a lot of potential within your contracts to be able to optimize the reimbursement. And you need to be mindful, like for instance, this dentist asked me, well, if I go out of network, I'm going to be able to use my UCR fees. And one thing that is happening on the contracting side is every employer has a different purchasing power. And you may have one employer that allows for the, for the allowable amount to be following your office private fees, which a lot of times are under positioned, right? But then you may have another employer that is going to be following an in-network. So that's a separate conversation. But I totally get your point. And that's like such an important piece of information and advice that you just shared, because they need to hear it over and over and over again until and it makes sense. So
yes.
That's awesome. So my second question has to do with, I hear you and I follow you, and you have a Facebook group now where you share a lot of information and training about, misconceptions and things that we come. And I'll give you the perfect example, something that I learned from you when we started, when we started our friendship and work relationship, which was you opened up my eyes to so many different coding scenarios for one encounter in a dental office. And I said, I had a misconception about billing, and my billing experience is limited to what I was exposed to as as working in a dental office that performs 10, 30 procedure codes on a regular basis. So what are some misconceptions that you see about billing in dental offices that you frequently encounter as you're working with your clients?
So I think that there's a twofold answer to that. So I think the first part A would be understand that what insurance companies and their guidelines were 5 years ago, 10 years ago, are no longer the same, right? So just as codes are removed and added, so are payment guidelines. Payment guidelines are removed, updated, or revised, and sometimes they have new guidelines, or they add new guidelines, or they're willing to accept certain combo procedures to codes to be billed on the same date of service. So one of the common misconceptions that I see revolves around the Prophy interaction. And you and I both know that Prophys are the #1 procedure. It's either going to be Prophy or recall for the standard general practice. It's usually recall and then Prophy, or vice versa, in the top 30 procedure codes in that mix, right? So with that being said, with Prophy being the #1 procedure that we're interacting with our patients with, we want to maximize on the Prophy interactions. And a lot of times what I see is I see a hygienist that will document a bloody bib Prophy without realizing that we could have stopped and probed around the area that was maybe had some moderate bleeding. And if the perio pocket depth around that isolated bleeding area during a Prophy interaction measured 5 millimeters or greater, then as your biller, I could have billed limited SRPs in addition to the Prophy. And that's where the common misconception comes in today's billing landscape, is that we're not understanding that payment guidelines have evolved. Insurance companies are paying for procedures that they didn't pay for in a combo setting 5, 10 years ago. So I will hear a lot of, experienced billers like myself. I've been doing billing since 1995. I've seen it evolve. I've gone through all the payment, the payment guideline changes. I've kept up with all of that. So, you'll hear a lot of people that have not kept up on all of that say you cannot bill those procedures together. And I'm here to tell you that you can. Does that mean that every single plan is going to pay for it? No, these things are allowed, but that doesn't mean that every plan is going to allow it, because there are plan specific guidelines. And when you're talking about plan specific guidelines, the fully insured plans versus the self-funded plans, they're going to pay completely different in two different ways. And so there's so many things that we need to understand, but let's go back to the Prophy interactions and limited SRPs. You can absolutely bill those on the same day. That is allowed.
That's great information. I hope you guys are learning from this. Can I get some feedback? Are we still good? Let us know if you're learning something. If you have any questions or anything, let us know in the comments. We have over like 10 people live.
Nice.
And I can't, and I'm not the best at monitoring. Okay, so I have a question. Let me put it on the chat here for you.
Okay.
So even with the same insurance companies, they may have a different out-of-network allowable. For example, some Aetna will pay to UCR and some plans will pay $30 per exam. So that is absolutely right, doctor. So again, as Ericka was saying, how everything has evolved. So what on the contracting side of things, what at the benefit level. So this is the thing, dental insurance companies are either restructuring the reimbursement level or the benefit level for the patients. And so you may have a patient, you have Aetna, which is the carrier, but you may have a group policy that has a benefit level that is totally different than somebody else based on their purchasing power. And so what that means is that, yes, you may have some Aetna policies that will follow the UCR fees, while others may pay you typically the average in-network rate within the area or a fixed fee schedule. So it's plan specific. He posted another question here. Let's throw it in the chat. What's the best way? Are you able to read it, Ericka?
Yes.
Awesome.
What's the best way to find out? Let's say we have a new patient coming in tomorrow for new patient exam. Okay, so I call this it's a very important question that we have to ask on the breakdown of benefits when we're talking about the Prophy interactions with limited SRPs. Now, I want to back up a little bit, and I want to just explain that when I'm talking about the Prophy interaction and limited SRPs, yes, you can diagnose that during the new patient exam, but I'm also talking about your full schedule, like all of your patients that are coming in for a Prophy. We need to ask if the insurance company will allow D1110 and D4342 on the same date of service. And you'll find that 60% of the time they will allow it and pay for it on the same day of service. Now, what happens if we don't ask that question and we do those two and we bill it? Typically, the insurance company will deny payment for the Prophy and pay for the limited SRPs because they most of the time want you to treat the SRPs and the infection before you do the Prophy. And they'll give you a waiting period of, say, 14 days before they want you to bring the patient back for the Prophy. So it's important that we understand that going into the Prophy visit, because let's say that the hygienist is in there and the hygienist, he or she comes across area where there's moderate bleeding, and they probe the area. They find that yes, there is some infection there. They're going to do what they've always done, by the way. Just as a side note, I know this is the case because I have surveyed over 300 hygienists and asked them, when you have a patient who has moderate bleeding in a specific area during a Prophy, do you go deeper under the gum line and take care of that? And across the board, it was a Yes, yes, we do. So they're already doing it. They just don't know how to document for it, which allows me as a biller to bill it, right? Because we want to make sure that we're not just slapping it on a claim form just for the sake of putting it on there. I want everybody to pass an audit. We don't want codes going on a claim form that don't match the clinical documentation. And so, there's a very specific workflow to this, and it starts with asking the insurance if you can do these two procedures together or not. I have offices that don't bother with all of that because they're just too short staffed and their team can't take the time to pick up the phone and call the insurance company. So if the hygienist comes across an area that has moderate bleeding, they will go ahead and treat that, document it. For documentation, I need the tooth number, the periocytes, and that's pretty much it. Limited SRPs documented in that area. And now I can put it on the claim form. If it's not allowed, like I said, they will deny the Prophy, and we will receive the higher reimbursement for limited SRP. At that point, it's a business call for you. I mean, it's your practice. At that point, you can decide to bill the patient for the Prophy that was denied, have the patient pay for the Prophy, get them reimbursed. It's a total business call at that point. But you will get reimbursed the higher rate of limited SRPs, which is, probably in the range of anywhere from, 100, 150. I've seen it get reimbursed up to $200 per area for limited SRPs. So I could talk a lot about this.
I know, and I have so many questions, and the audience is also asking so many questions, and we're gonna try to get to everyone. So just bear with me.
Yes.
I am coming up with my own questions that are totally
Yes.
off, like my original list of things, because you just every time you're just bringing out so much awareness and so much
Yes.
valuable information. So we have Tanya, Dr. Tanya is saying, what codes do I bill for the Prophy with limited SRPs?
That would be D1110 for your adult Prophy. And the patient does need to be an full adult dentition, obviously. And that's just the biller in me. And then D4342 for the limited SRPs.
Got it. And so my question to you is, and this is a follow-up question because it has nothing, and I think I totally lost my train of thought here. So does that change the exam code, right? So let's say a patient was coming in for the 0150 and with the 0150, now that I have this, area of bleeding and the hygienist, when I do the SRP codes, do I then change the exam code, or can I do the 0150 still?
Okay, so that's actually a great question. This comes up a lot with my offices. So we have two comprehensive
exams too, by the way. And
we have two different exam codes, and the one that I see underutilized is the D0180, which is the comprehensive periodontal exam. And this is appropriate for any general dentist to use. I find that general offices typically avoid using this, thinking that it is specific to a periodontist. However, it is not. It is for individuals who have or are at risk and show signs and symptoms of perio. So when the patient is diagnosed with SRPs, I would prefer that my billers, my students, I teach them to put D0180 as opposed to 150, because 180 should also be reimbursing you more, considering when a patient is diagnosed with perio, we have to spend more time with the patient, and higher reimbursement would be appropriate. I wish it was more than what it is, but unfortunately, it is what it is. But at minimum, 180 should be paying $30 to $40 more for that exam, because we are explaining to the patient what perio is, how they got it, how we're going to treat it, and so on and so forth. So 180. Both are allowed once in a lifetime per provider with most plans. And if a patient comes in for recall and they are newly diagnosed with perio, then I would put, rather than putting D0120 for recall, I will bill D0180 because we did a comprehensive perio exam considering the patient is now newly diagnosed. So we're not talking about a patient who, I've seen this happen. The patient had SRPs 5 years ago, and you know, we have not done, it's an existing patient, and we have not done an exam on the patient, you know, recently, or this recall visit. It's a patient that has never had perio on file, newly diagnosed when they are here for a recall visit. And I would recommend that we do that. Now, when we do that, a lot of insurance companies are going to try and remap that or recode it or downcode it to a recall because we don't have the appropriate narrative there. So we need to make sure that we're telling the insurance company, yes, we understand that this is a existing patient. However, you know, the patient has been newly diagnosed with periodontal disease on this date of exam. Patient is scheduled to return for scaling and root planning, so that the insurance company knows that this was a true comprehensive perio exam appropriately.
My goodness, so many misconceptions in dental offices. And I want to be mindful and respectful of your time because I do have other questions coming up, but
Yes.
we have to get through my list of
Yes.
questions. And then I'm going to make sure that you all have Ericka's information to pick her brain and schedule, you know, a discovery
Yes,
call with her and
please
learn
do.
more about how she can help your practices. But I'm going to continue going through my question here, which is the billing cycle, right? So it is so important to just continue to learn based on what I'm understanding. The changes that are happening with dental insurance companies is just very difficult to keep up with. And so understanding what questions to ask regularly and based on what is happening clinically in your practice and the communication with the patient is so crucial. So can you explain, you know, what the billing cycle should look like in a dental office?
Oh, okay. So now we're talking about submitting clean claims. And clean claims are life when it comes to the billing cycle. And the clean claim is defined by Medicare as submitting a claim that allows the insurance company to make a swift and prompt decision as to pay or deny. When an insurance company is asking for additional information, that is the indicator that we did not submit a clean claim. So if the perfect billing cycle would consist of, you know, just making sure that we have all of the correct demographic information, you know, making sure that the patient's date of birth is accurate, making sure that we have the right subscriber, the dependent status. This is a very common reason for denial, and it's avoidable. So we want to make sure that, and then second, we want to make sure that we are putting narratives together that are supporting dental or medical necessity. And I find that a lot of narratives out there are halfway supporting dental or medical necessity, but we need to speak the language. We need to understand the lingo that the insurance company likes to see in the narrative. And specifically, they like to see when we are, for example, billing for a crown. They want to know that we're doing a crown to restore the function of the tooth. So we need to speak that language that is actually within the definition of dental necessity, you know, to restore function. And so we want to make sure that we are incorporating the verbiage that is included in what the insurance companies define as dental necessity or medical necessity if we're billing for SRPs, you know, including risk factors and things like that. So that would improve the billing cycle, is understanding how to create a very a proper narrative, and kicker, like just a little bit, elevate that a little bit more, making sure that your narratives are less than 80 characters, because a lot of over 70% of our claims are auto adjudicated, and they cut your narrative off at 86 characters, and this includes the spaces. So we have to get
interesting.
yes, we have to get
every time I talk to you, I learn something.
we have to get really good at making those narratives really concise, and just get straight to the point, because they're not being read by humans anymore. They are just going to pick up 86 characters, and hopefully you made your point before that. And so you just want to get really good at that. And then finally, and this is a biggie for the clinical side, I don't think that the clinical side understands how they affect my ability as a biller to submit a clean claim. It's not just my efforts. It's not just based on my efforts. It's also based on my assistant's efforts to get me a really good PA, a really good intraoral, or even understanding when I need a PA, what it needs to look like. So in my book, The Dental Billing Guide, that I just recently released, and I have an attachment guide, and I like to use that for my clinical teams, specifically my assistants. I want them to understand, for the top procedures that we bill in this practice, this is what I need in order to submit a clean claim. And, I always talk about billing starting in the back, Maritza, because it really does. The clinical documentation and the x-rays, the clarity, and understanding when I need an intraoral photo, so important. So to, just kind of go back to your questions, what does a good billing cycle look like? That's what it is. It's the ability to submit a clean claim without any denial or additional information.
And it's
Sorry, without any.
So
yes,
it starts with the demographic information, right? Just capturing the information that you need to submit that clean claim. Then having all the narratives and understanding the limitations that you have now, that everything is AI driven, and that you're not going to have like a lot of doctors, and I see this massive narratives are for appeals or something beyond that. But if it's just for this, encounter where your patient that came in for just a regular prophy, but happens to be newly diagnosed with, perio situation, and you now need to restructure the coding in order to meet the encounter that took place with the bleeding and the hygienist, to optimize the reimbursement and not have this, hidden like profits that are sitting there by just that encounter alone, and just that misconception of, oh, this is what the patient is scheduled for. And regardless of what happened down back in the back, I see dental offices that the billers or their billing departments, they see the scheduled visit, scheduled for, recall with the prophy and the 4-bite wins, whatever that may be. They just they glance at the clinical notes and, okay, patient visit was completed by the clinical provider. They don't take the extra time to read and say, patient had bleeding gums today, and I went through this extra little step that changes things, because we're always trying to just go through the day and finish the billing. And this is where there's so many hidden, profits within your billing cycle. So this is great. I mean, so thank you so much for outlining the billing cycle. My last question, and then if you have time, you let us know, then we can open up.
I always have time for this. This is fun for me.
So my final question is reporting. Like, what kinds of reports? Like, I'm already going through all of these things in my practice, and I want to be able to go back and read out the clinical notes, make sure that I have. And I think that you have this amazing narratives, resource that I would love for you to share with, with our audience. But like, what kind of reports do you recommend to make sure that I assess my billing department, and then I sort of like take back control of it, and I start to incorporate changes and things that are going to help me, like improve my collections and improve my profits?
So the first one is really understanding as an owner how to read an outstanding account receivable report. Um, obviously we want to make sure that we keep it as clean as possible. A lot of times, but by the time I'm having a conversation with a doctor who's concerned about the AR, there's problems, there's issues. So I think the first thing when you're trying to understand what's going on in your billing department is running your account receivable report and understanding that only 3% of all insurance money owed to the practice should be in the 90 plus day column, right? So you can run a specific insurance account receivable report, and your 90 plus day column should not be heavier than 3% of all insurance money owed to the practice. And what I have found is most offices are in the 20 to 40. I've seen it as high as 70% of all the insurance money owed to the practice stuck in the 90 plus day column. And so what that tells me is we have a problem with the billing cycle. Obviously, we have somebody who's mismanaging the billing cycle. Maybe we're short-staffed, which is the case a lot of times right now. It's just we're short-staffed and we just can't seem to get to the claims. Now, this does not mean that the claims have been paid and the money's gone. It could just mean that you have been paid, but we haven't been able to post the payments yet. So this just means that these claims have not been closed. So when I see a messy account receivable report like that, the first question I ask is, are you guys behind on posting payments? And if they say, no, we're up to date, now I've got a different spidey sense going off, because now I'm like, okay, well, why are the claims still open? And that's a whole other conversation. But understand that your account receivable report doesn't necessarily mean that it's a reflection of your biller's performance. It could mean so many other things. You review it. I think accountability is lacking in a lot of dental practices, and we can't chalk it up to just not having time for it, because if you don't make time for it, your needle's never going to move. And that's why these meetings, they don't have to be 1 hour meetings. They can be a 15-minute concise meeting, but just a matter of just sitting down and going over AR with your biller or whoever you hold accountable for the billing department, because whether or not you think you have a department, you do. You may be a small practice, but you are a small business, and you do have a sales department. You do have a billing department. You have a scheduling department. You have departments, and each department has KPIs that need to be carried out in order to have a successful practice overall. So understanding that those meetings are going to be the accountability factor with regards to making sure that the needle is trending in the right direction. And so if you guys have any questions on how to hold a proper billing department meeting, reach out to me, and I'd be happy to talk to you about it, because accountability is also causing money to just kind of leak through the cracks. And go over, have your biller or the person you're going to meet with account receivable report. Have that person highlight the claims that are 6 months or older, because those claims are going to time out, right? Because insurance companies give us a certain amount of time to resubmit additional information that they've requested or receive the claim in the first place. And a lot of times, especially if you're using a clearinghouse, you'll create the claim inside the practice management software, and the clearinghouse will say, okay, we sent it, and the insurance company never got it. It just went into the abyss. And we don't follow up. There's no real follow-up strategy in place, and no meeting to hold anybody accountable. So these claims continue to age. And if it's never been received by the insurance company, the date of service is going to time out. So if the insurance company says you have 6 months to submit a claim from the date of service, and nobody followed up until it was too late, you're just going to not receive payment because the claim timed out. So when you start to look at account receivable reports, look at them with starting with the oldest. I always say highlight the claims that are 6 months or older. Go onto the insurance portals and confirm that the insurance companies have received those claims. And even if it timed out, even if it's older than 6 months, try and get that claim paid. You can appeal that decision. If it's timed out and they deny due to timely filing, always appeal that. So
Awesome.
I could talk all day
Yes,
about stuff like this,
and
but
speaking, just because we're about to wrap up,
yes,
one thing that is
Yes.
really crucial that I've heard you say on your group the other day was about the number of the stats on appeals from dental
yes.
practices. So I just want you to give everyone a teaser,
Yeah.
and then we'll wrap up because I have to
Okay.
run and I want to be respectful of your time.
Okay.
But yeah,
So in 2022, only 33% of claims that were denied ever got appealed. And I'm going to park it. Like, I'm just going to leave it there. So that just tells me, as a billing industry, as billers, as an industry, billing industry, we need to do better as billers. That is unacceptable. And if we don't agree with a decision, we need to appeal it, because insurance companies will give offices that don't appeal more denials than offices that actually appeal. And that's a fact.
this is a game, and we have to get good at the game. And training and awareness and mentorship and guidance is so crucial
Yes.
during this time more than ever. So we're going to take one last question, and then I'm going to let Ericka wrap up. So thank you all for being here. Is it better to have a code added to a fee schedule, or just try to bill in non-cover service 20% off your denied down coded? I'm not sure that I understand this question.
I don't understand the question. Thank you for being here.
Okay. So not sure if this is the same person we have. I think we're going to need to probably, on the description of this live, I'm going to make sure that I enter Ericka's link so that you guys can schedule a time with her. And then if it makes sense, then you can definitely, she would be the person that I recommend you reach out to. So this last question comes from an LinkedIn user. If an office hire for a part-time dentist, does the office bill through the primary doctor, or does the incoming need to apply to all the insurance plans? So this is a question I would say more in my realm. It depends. But on a clean claim, you have the entity or the group that it's submitting for the claim, and you can be, as the treating dentist, either being the treating dentist that is treating the patient as out of network, or you can be in network. But when a dentist hires a part-time dentist on the claim, the insurance companies want to see the treating dentist, whomever is encountering or rendering the service to the patient, needs to be on that claim. And a lot of times, if the provider is meant to be out of network temporarily, you can just basically update the clearinghouse, update the insurance company. You can come up with, at your business discretion, depending on your status with the insurance company, come up with a strategy that works for the patient or something to that extent at your discretion. But on the claim, they want to see the treating provider. Doesn't matter whether the provider is in network or not. So I hope that answers your question. So this has been so helpful. Everyone, thank you so much for joining us. As I said before, I think we left more questions than we came in with. But to wrap up, I think that I just basically want you to give one last piece of advice, and how do we find you? How do we stay in touch with you? And how can we gain access to some of those amazing resources that I know you've put together for your students, myself included?
Thank you. So I'm on LinkedIn. I have a group on LinkedIn called Academy of Dental Practice Management. We have about 500 or 600 members in there right now. So definitely on LinkedIn, in the group, you can find me, Ericka Aguilar, and I'm on Instagram as the Dental Billing Coach. underscore dental underscore billing underscore coach, dental billing coach. And then outside of that, you can message me any questions that you have, and then I will give, or you have my link, and you can direct message me, text me through that link. So I'm always here and up for having any type of billing conversation. Any
I think we have to do another workshop or something together.
I'm actually going to be hosting a workshop with. I host workshops all over the country, friends, of on coding and billing. And we are going to be in Riverside, California this Sunday. So we have a nice group of offices coming, and hopefully, actually not hopefully, they're going to learn a lot. So I'm really excited about that. I know you were with me in Los Angeles. It was so fun. It was so fun. I think when you put us in the same room, it's like sparks everywhere. It was just so fun. But yeah, I thank you so much for having me here. There's so much that I want to share about coding and billing. So if anybody has any questions, just let me know.
Thank you so much for your time. I think that that everyone has been so interactive. This is one of the mostly commented lives that I've done. So thank you for shining so much knowledge and your experience. I mean, it's just experience cannot be improvised. And every time I talk to you, I'm very selective. And you're one of those people that I will continue to say I have such great admiration for you, and I'm so lucky and so honored to be able to call you a friend and a colleague. So thank you so much. We will stay in touch. And everyone, thank you so much for joining us today until the end. And I look forward to seeing you guys next week. Everyone is saying thank you for great information. Bye-bye.